Good evening. Welcome. The topic for this evening's Immunisation Coalition webinar is pneumococcal disease, an update for 2025. I'm Andrew Baird. I will be your moderator tonight. I'm a GP in Melbourne and a member of the Immunisation Coalition. I would like to acknowledge the traditional custodians of the various lands on which we work today, and to acknowledge the Aboriginal and Torres Strait Islander people participating in this webinar. I pay my respects to elders past, present and emerging, and I celebrate the diversity of Aboriginal peoples and their ongoing cultures and their connections to the lands and the waters of Australia. Presenting tonight's session is Angela Newbound, who will be speaking for 40 minutes. There will then be 20 minutes for us to answer your questions. Please type questions in via the Q&A button at the bottom of your screen, and you can do this at any time during the session. We will try to answer as many questions as possible. For questions that are not answered, we will send responses over the next few days. You can use the chat function to communicate with other participants online. The presentation will be recorded and all participants will be on mute. At the conclusion of tonight's webinar, you will receive an evaluation form. It'll take about 2 minutes to complete. Please fill it out so that we can continuously improve the quality of our education activities. Angela Newbound is a nurse, an immunisation education consultant and a member of the Immunisation Coalition. Angela has been involved in immunisation programme delivery in South Australia for about 25 years, originally as an immunisation provider and then in programme coordinator roles until December of last year with divisions of general practice, Medicare local networks, primary health networks and the South Australia Health Immunisation section. Angela continues to provide clinical advice and nurse education across a variety of platforms. And Angela is very passionate about vaccination and the role immunisers play in vaccinating the public. Angela, thank you for joining us and welcome.
Thank you very much, Andrew. What a kind introduction. Yes, I certainly am very passionate, and one of my absolute loves in life, which is a bit of a strange love in life really, is this complex disease of pneumococcal disease and a complex vaccination program of pneumococcal vaccination. So now that you've known a little bit more about me, I'd just like to take a quick minute and just ask if you could respond here to where my audience sits in the field of health professionals. So I'll just give you a moment to tick a box. Perfect. Oh, great. We've got a really a fabulous mix of people. So 27% general practitioners, or medical practitioners, 59% nurses, midwives, immunisation practitioners, pharmacists, 10%. We've got a little smattering of others. That's fantastic. Thank you very much for letting me know. So I think probably, with all of our education, there are some learning objectives, which I have listed here. And we're certainly going to go through and just sort of touch over really the burden of pneumococcal disease and the benefits of pneumococcal vaccination, and particularly trying to identify those that are certainly at higher risk. We're going to talk about these higher valency pneumococcal vaccines that are now available. We've got a PCV 15 and a PCV 20, and we'll just chat a little bit around about the safety of these vaccines as well. So we'll start off with a poll just to test your knowledge a little bit, just to keep us all awake. So what causes pneumococcal disease? Is it A, Streptococcus pneumoniae, or B, Staphylococcus pneumoniae, C, Staphylococcus aureus, or D, Streptococcus alactactes? So we give you a few seconds there to tick a box and see how you go. Okay, so how did we all go with that poll? Ah, pretty good. Well done. So yes, of course, our answer is A, Streptococcus pneumoniae is the causative agent. Couple of other answers there, but definitely A was your correct answer. So Streptococcus pneumoniae, certainly isolated many, many years ago by Pasteur, 1881 in fact. It's a really opportunistic pathogen that just colonizes the mucosal surfaces of the human upper respiratory tract, and probably around, oh, well, the estimates are anything from about 25% through to about 65% of children, and around about 10%, maybe up to 10% of adults are actually carriers of strep pneumoniae. And that carriage is really quite a quite a happy relationship, I suppose, really, between the bacterium and the host, not necessarily causing any significant disease. But it certainly has the ability to really shift from that happy relationship with its host to being a really pathogenic interaction with the host. And a lot of these pneumococci are encapsulated, which means that their surfaces are composed of these complex polysaccharides, and those encapsulated organisms are really pathogenic for humans. And it's that the bacteria's polysaccharide capsule that helps it really resist phagocytosis and is really the most important virulence factor of pneumococci. There's around about 95 capsular antigenic types or serotypes, and each of those serotypes elicit a type-specific immunity. And we know that worldwide, a small number of serotypes will be the cause of pneumococcal disease, but the prominent serotypes vary in different age groups and in different geographic areas. But there are some serotypes that cause more severe disease. And serotype 3 is probably our biggest problem serotype. It's often referred to as the sugar-coated killer. And the capsule of that serotype 3 is really thick. It's got an extended polysaccharide layer, which really favors nasopharyngeal carriage and resists that antibody-mediated clearance. So we know that with pneumococcal disease, there's a wide spectrum of illnesses that it can cause. Obviously, a lot of otitis media in children, sinusitis, to much more serious illnesses such as your bacteremia, your meningitis, etc. And if we have a little look at this particular diagram, we can see how pneumococcal disease is either characterized as being invasive disease or non-invasive disease. And obviously non-invasive disease means that these are conditions that occur outside of the major organs or the blood, such as otitis media. So we know that if we were to do middle ear aspirates on children, we know that probably about anywhere between 28 and 55% of those aspirates, would grow strep pneumoniae. And so this really is quite a significant problem for little children and can obviously lead into permanent hearing loss. We know that, pneumococcal pneumonia causes, quite significant morbidity and mortality, predominantly, of course, in the elderly and the immune compromised. But we certainly do know that this type of a respiratory infection disease burden can be really likely under representative. And so whilst pneumonia is kind of a non-invasive, it can also be classified as invasive, and we'll talk about the invasive disease just shortly. Prevention, of course, is always better than the cure. And we certainly know that there's growing antibiotic resistance, and that really means that patients may need to be prescribed a combination of antibiotics. So definitely talk to all of your patients around the benefits of having pneumococcal vaccines, just to reduce that likelihood of actually having pneumococcal disease, but certainly becoming very, very unwell with pneumococcal disease. So if we look at invasive pneumococcal disease, you can see there that one of the major presentations of IPD, or invasive pneumococcal disease, is pneumococcal pneumonia. So, we certainly know that these sorts of respiratory infections, can certainly lead to pneumonia, which will hospitalize people, certainly can become so severe that people may well die from it. We know that pneumococcal disease most likely and most commonly presents as either a septicemia or a meningitis or a pneumonia. Septicemia and meningitis are more common in children, so about 70% of cases, with the exception of Aboriginal children, who present most commonly with pneumonia. Most adults with IPD will have pneumonia with bacteremia. And of course, there's just those other less common presentations that can occur. So it's been a notifiable disease in Australia since 2001. The number of notifications fell really dramatically after vaccines were introduced in infants. However, IPD rates remain higher amongst the youngest in our community and the oldest in our community. And the notification rate has remained consistently higher among Indigenous Australians than for other Australians. So it's really exceptionally important for providers to continue to ask your patients or your clients, do you identify yourself or your child as Aboriginal or Torres Strait Islander? Always follow that question up with for the reason that you're asking the question. Otherwise, they still may be quite hesitant to say yes because they don't know really why you're asking the question. And if they were to say yes, am I going to get treated differently? So please just follow up with that question. Do you identify yourself or your child as Aboriginal or Torres Strait Islander? Because if you do, there are some additional vaccines recommended for you to offer you a little bit more protection because you're at greater risk. So just following it up is really important. So geographically, case numbers differ quite significantly. So this is Department of Health data from the National Notifiable Disease Surveillance System, which I looked at on the 3rd of June, and you can actually see the numbers of cases that have been reported around the country, and they vary reasonably significantly. And if we have a little look at this particular table here, once again, you can see the total case numbers of notifications. And it's been really recognised for a considerable time period that, respiratory infections can predispose patients to become bacterial infections. And these co-infections, so these viral illnesses that become a bacterial infection, have a worse outcome than either of those infections on their own. And you can certainly see there was a decrease in notifications during the 2 COVID pandemic years, possibly because we had very little circulating flu cases. We had social isolation, we had distancing, we had mask wearing, and all of those other infection control strategies. But certainly you can see that case numbers are rising again and clearly returning to, and as we saw in 2024, exceeding pre-pandemic levels. So if we look at this graph, you can see, clearly demonstrates that notifications are really highest in very young individuals and individuals from 50 years and older. And when I looked at this data on the 6th of June, so about 3 and a bit weeks ago, of the 633 notifications reported to that date from the 1st of January this year, 121 of those notifications were in children less than 9 years of age, and 353 notifications in people aged 50 and older. So they certainly are our 2 groups that we need to be very, very aware of. So who is at risk of invasive pneumococcal disease? And the list is really quite long. This list is available in the immunisation handbook. It's available on the ATAGI advice that was released in 2020 when the pneumococcal vaccination recommendations changed. So if you haven't got a copy of it, they are available for you to download. So whilst there's a lot of medical conditions on this list, not all of those medical conditions are eligible for funded vaccine. So let's just take a look at some of these conditions in a little bit more detail. So if we're looking at people with these underlying chronic conditions, due to the nature of these conditions, these people are at increased risk of community-acquired pneumonia, or CAP as we abbreviate it, as well as invasive pneumococcal disease, or IPD, all year round, not only during the winter, unlike seasonal influenza. People with COPD, asthma, or who smoke, and those with chronic heart disease or diabetes have been shown to be at real increased risk of pneumococcal disease compared to those that do not have those risk factors. These conditions and even cigarette smoking can also adversely affect patient outcomes and really long-term and short-term, and certainly mortality rates following pneumonia. Community-acquired pneumonia, in particular, pneumococcal pneumonia, is certainly associated with really high, not only economic burden, but certainly on our health system for people being hospitalised. And it has this long-term impact on the patient's quality of life. And you may have come across this with some of your patients that have had pneumococcal pneumonia. They just seem to never really bounce back like they were before. And so if we're really serious about healthy aging and frailty in our older populations, we really need to think about how these diseases that are vaccine preventable, or certainly reducing their likelihood of severe disease, can certainly help them age well. We know that both COPD and diabetes have been significant predictors of hospitalisation in patients with community-acquired pneumonia, and certainly anybody that does have other lung and heart disease. So if we're looking at people with diabetes, for example. We know that the greatest impact for those, the risk of IPD as well as CAP, particularly in those that are under 64 years of age, and especially even in those that are less than 40 years of age. There was a Danish case-controlled study where they looked at individuals that were less than 40 years of age with diabetes, and they were found to have a threefold higher risk of hospitalisation due to pneumonia than individuals without diabetes of a similar age. And it's really been suggested that that increased risk of pneumococcal infections in patients with diabetes results from that harmful effect of hyperglycemia on immune and or pulmonary function. And due to the ongoing subclinical inflammation following recovery from pneumonia, deterioration of underlying cardiovascular disease has been increased, associated with an increased 1-year mortality following pneumonia in patients with diabetes versus those without diabetes. So definitely very, very significant group. This is all in the immunisation handbook, and so you can certainly read more about that risk. If we're looking at people with chronic heart disease, and that includes congestive heart failure and cardiovascular and valve disease, have up to a 3.3-fold increased risk of community-acquired pneumonia and up to a 9.9-fold increased risk of invasive pneumococcal disease compared to those without chronic heart disease. And they sort of, you know, we know that age itself is a risk factor for pneumococcal disease, and we saw that on the graph a little bit earlier, where once you get to 50 years of age, you know, the risk increases significantly. So we know there was a hospital-based epidemiological study of invasive pneumococcal disease in adults that was undertaken in Belgium, and that certainly also demonstrated a really significantly higher case fatality rate during hospitalisation in those individuals with heart failure compared to those without heart failure. So another risk group to keep your eyes on. And once again, recommendations are there for you to read. So patients with chronic respiratory disease, so that includes your COPD, your chronic bronchitis and or asthma, are at higher risk of community-acquired pneumonia as well as IPD than individuals without those types of comorbidities, with fold increases of between 1.3 and 13.5 for community-acquired pneumonia and 1.3 to 16.8 for invasive pneumococcal disease. Having COPD often means the use of inhaled corticosteroids, and this, in addition to increasing age and perhaps lack of pneumococcal vaccination, have really been identified as independent factors for recurrent community-acquired pneumonia in adults. And because patients with chronic respiratory disease have that reduced innate defense mechanisms of the airway, ongoing subclinical inflammation following recovery from pneumonia has certainly been reported. Severe asthma, it's an interesting term, but it's really defined as requiring frequent hospital visits or the use of multiple medications. Now, this is yet another condition that is not funded under the NIP for pneumococcal vaccination. We know that asthma is a chronic inflammatory disease, and it's characterised by that airway hyperresponsiveness, that airway inflammation, and that reversible airflow obstruction and airway wall remodeling. And that respiratory epithelium is that first line of defense against inhaled pathogenic agents, and that bronchial epithelium of asthmatic patients is, morphologically abnormal. And so this probably explains why people with asthma have an increased risk of invasive pneumococcal disease. So they also, asthmatic patients also have that impaired clearance of any airway debris, and therefore that can also serve as a focal point for that localized infection that can certainly develop into an invasive bacterial infection. Smoking. So if you have patients who are smoking, obviously you are going to be trying to encourage them to give up. There's really no benefits at all to tobacco smoking. So compared with adults who have never smoked, current smokers or even ex-smokers were found to have a higher risk of community-acquired pneumonia, and individuals aged greater than 65 years who have never smoked but were exposed to passive smoking were also at significantly increased risk. And there was an Australian study that was done in 2011 that showed that smokers were 3.7 times more likely to develop pneumococcal bacteremic pneumonia than non-smokers. So absolutely encourage your patients to give up smoking. So great that we have these vaccines. There's been lots of changes with the National Immunisation Program, or the NIP, over the years, and there's certainly now 2 extended valency vaccines. There's 20-valent pneumococcal conjugate vaccine, that's called Prevnar 20, and a 15-valent pneumococcal conjugate vaccine called Vaxneuvance. However, they're not listed currently on the NIP. They are only available on the private market, but you can certainly consider using these vaccines in those individuals that are at risk of pneumococcal disease, and especially for those who are not eligible for the NIP funded vaccines. Both of these vaccines are registered for use in people from 6 weeks of age. So just to make sure that we're all awake, once again, this is our second poll. So what is the difference between Prevnar 13 and Pneumovax 23? Is it A, that Prevnar 13 is a 13-strain polysaccharide vaccine and Pneumovax 23 is a 23-strain conjugate vaccine? Or is it B, Prevnar 13 is a 13-strain conjugate and Pneumovax 23 is a 23-strain polysaccharide? Or C, they are both conjugate vaccines but contain a different number of strains? Or D, they are both polysaccharide vaccines but contain a different number of strains? So I'll give you a couple of minutes here. Okay, so let's see what our results there. Oh, so we've got quite a bit of a smattering. 16% said A, 57% said B, 20% said C, and 7% said D. So the correct answer is B. So Prevnar 13 is a 13-strain conjugate vaccine, and Pneumovax 23 is a 23-strain polysaccharide vaccine. So really, what does all of that mean? And so for any of the providers that are watching this webinar, that you may not be aware of what that term conjugate means, it really means that there's it's a type of bacterial vaccine that's made by chemically linking or conjugating the protein that's on the surface. So we talked about those polysaccharides on the capsule of strep pneumoniae, or the bacteria itself. And so what the brilliant people in the world have done is they've taken off a piece of that little polysaccharide coating and they've conjugated it or chemically linked it to a carrier protein. So by doing that, it really improves the immune response to the vaccine. And you've got other conjugate vaccines in your fridge, such as your Hib vaccine, your meningococcal ACWY vaccine, and certainly you've got a range now of these conjugate pneumococcal vaccines. The polysaccharide vaccines, so the vaccines that are just made of the sugary coating, the polysaccharides on the surface of the bacteria, they don't really elicit a very strong T cell response. So by binding that little piece of polysaccharide to a carrier protein has really demonstrated to allow that T cell dependent processing of that polysaccharide antigen. And for example, the Prevnar 13, that polysaccharide from the coating of the bacteria has been chemically linked to a non-toxic diphtheria CRM197 protein. So I hope that kind of makes a little bit more sense. So if children less than 5 years have certainly not received their routine Prevnar 13 vaccines, please catch them up. There are appropriate catch-up tables that will direct you into what doses that they should be receiving. But it is certainly funded as part of the infant program. 13-valent is also on the national program for adults, so Aboriginal and Torres Strait Islander adults, 50 years of age and older, without any risk conditions. Non-Aboriginal and Torres Strait Islander people at 70 and older. There is no upper age limit, by the way, so if people have not had their pneumococcal vaccine and perhaps they're a non-Aboriginal adult and they're now 82 years of age and they've never had a conjugate pneumococcal vaccine, please recall them in and get them vaccinated. Individuals that have certain but not all of those risk conditions we talked about earlier, and certainly the 3 doses that are required for your individuals that have received a hematopoietic stem cell transplant are covered under the National Immunisation Program. So I should have changed Zostavax there to Shingrix, my apologies. So can Prevnar 13 be co-administered with Shingrix and flu vaccines? Is it A, no, the combination should be avoided. B, Prevnar 13 can be given with Shingrix, but not with influenza vaccines. Or C, Prevnar 13 can be given with influenza vaccine, but not with Shingrix vaccine. Or Prevnar 13 can be given with influenza and Shingrix vaccines. Let's see what that says. And how did we go? Oh, okay, so pretty good. So D, yes, 82% got it right. So D is your answer. 16% said it was C, and only 1% for A and B. We just need to be aware that in infants, there is a possible small increased risk of fever if they have their Prevnar 13 at the same time as their influenza vaccine. At present, this possible risk has not been observed for the 15-valent pneumococcal vaccine, and there's no data really about that for 20-valent. So please advise your carers or your parents of infants and children who are recommended to receive, obviously, both influenza and 13-valent pneumococcal conjugate vaccine of this risk, making sure that they know how to observe for a fever, how to take a temperature, have they got a thermometer at home. Putting their hand on the child's forehead is not taking their temperature, all right? So see if they've got a thermometer at home, have they got appropriate paracetamol at home? Let them know when they should be worried and when they should be seeking some medical advice. Obviously, remember too that many patients who are recommended to have pneumococcal vaccines should be encouraged to have your COVID vaccine every month. So these are your older adults, and this can also be co-administered with these vaccines, including these pneumococcal vaccines. So remember, we can't overdose patients with these vaccines. If there is no written record that somebody has already received these vaccines, then we proceed as though they have never received these vaccines. Certainly do your best to try and locate the records, but if there is none found, vaccinate them and record it on the AIR. Now, we completely understand that some of your older patients may have received pneumococcal polysaccharide vaccine many, many years ago, and this would not be reflected on the Australian Immunisation Register because back then the provider couldn't report it to the register because it was a childhood immunisation register. So adult data has only been captured on the register since September 2016. So there could be missing data, but if you cannot find any written record, then you would proceed as though they have not received the vaccine. They may get a localized reaction, a little bit more extensive redness and swelling at the injection site, but that really is probably going to be about the worst of it. So we would rather see a dose reported on the AIR. Okay, so for those new providers, once again, remember we were talking about that polysaccharide coating around the outer surface of the bacteria. So our 23-valent pneumococcal polysaccharide vaccine just uses that piece of polysaccharide. There's no conjugation with a carrier protein. So polysaccharide vaccines will stimulate B cell responses and thereby result in a type-specific antibody production that sort of enhances that ingestion and killing of the pathogens by the phagocytes. The antigens, however, are T cell independent and do not induce that B cell memory, and therefore they don't have a long-lasting immunity. Polysaccharide vaccines are unable to induce an adequate antibody response in infants and children. So this vaccine is not recommended for children under 2 years of age. But since July 2020, with the change in the pneumococcal vaccination recommendations, it is not recommended for children under 4 years of age. So we know that the 23-valent pneumococcal polysaccharide vaccine can be administered either subcutaneously or intramuscularly. However, whenever we've got that opportunity to administer a vaccine, either subcut or IM is preferred. Always, before you administer any vaccine, please check the AIR prior to just ensure that there's been minimal intervals between previous polysaccharide or conjugate pneumococcal vaccines, making sure that if you possibly can, the number of recommended doses is not exceeded. So this number of recommended lifetime doses of 23-valent pneumococcal polysaccharide vaccine is limited to 2 doses in a lifetime. But like I said, we cannot overdose someone. So if there's no written record, then go ahead. And if they are recommended to have 2 doses of the polysaccharide vaccine because of the medical condition they have, then go ahead and administer it with 5-year minimum interval between the 2 doses of polysaccharide vaccine, and record it on the AIR. So there are 2 doses of the 23-valent that are listed on the NIP for certain individuals, Aboriginal and Torres Strait Islander people 50 years and older. So they would have a dose of the conjugate vaccine first, and then 2 doses of the polysaccharide vaccine. You would generally wait for 12 months after the dose of conjugate vaccine before you give dose 1 of the polysaccharide vaccine, and then wait for 5 years for dose 2 of the polysaccharide vaccine. You can shorten the interval between the conjugate vaccine and the first dose of polysaccharide down to 2 months if your individual is at significant risk because of their medical condition. Obviously, for individuals with certain medical conditions, they may have 2 doses on the NIP of polysaccharide vaccine. Your children aged 4 and over with medical conditions, and your Aboriginal and Torres Strait Islander children in South Australia, Western Australia, Queensland and Northern Territory at 4 years of age, and then a second dose 5 years later. So South Australia, Western Australia, Queensland and Northern Territory have an Aboriginal children's program, whereas other states and ACT territory does not have a program for Aboriginal children for pneumococcal or your hepatitis A vaccine. So the vaccines are not listed on the PBS. So if people are required to purchase these vaccines via private prescription because they're not eligible for NIP funded vaccines, then they would be paying full price for these vaccines. Okay, so our last poll for the evening. Okay, so your patient is 45 years of age, diagnosed with a hematological malignancy. They have had no pneumococcal vaccination history reported. What would be the current recommended pneumococcal vaccine schedule for this patient? Is it Prevnar 13 first, followed by 2 doses of Pneumovax 23, Prevnar 13 first, followed by only a single dose of Pneumovax 23? Or is it 23-valent first, followed by 1 dose of Prevnar 13, or Pneumovax 23 first, followed by 2 doses of Prevnar 13? Let's see what you come up with. Okay, how did we go, Anastasia? Oh, perfect. So 86% of you answered A, which is fantastic. 8 answered B, 3 answered C, and 4% answered D. So definitely A. So just remember, observe those minimum intervals, 12 months between the conjugate and the 23-valent, although that 2-month interval is acceptable. Make sure there's 5 years between those 2 polysaccharide vaccine doses. If a patient has actually already received a dose of the 23-valent pneumococcal polysaccharide vaccine, then the recommendation is that you do need to wait for 12 months before you can give that dose of Prevnar 13 or any other of the conjugate vaccines. Okay, so just very quickly, these are the extended valency vaccines. We'll talk about 15-valent first. The serotypes in red are the shared serotypes with the current Prevnar 13 that we use. Those that are highlighted in yellow are shared serotypes with Pneumovax 23. Once again, this is a conjugate vaccine. Once again, it's conjugated to a non-toxic diphtheria CRM197 protein, which is the same one that's used in your Prevnar 13. If we're looking at the new 20-valent vaccine, once again, conjugated to the same diphtheria CRM197 protein, it certainly offers the additional serotypes that you can see here. We do know that 22F and 33F type invasive pneumococcal disease are associated with a lower risk of death compared to PCV13 types. Those presenting with septicemia are more likely to have obviously a fatal outcome compared to pneumonias. So these vaccines are available, definitely, but we just can't win the game if we don't get them put into arms. So we definitely know that we need to increase our vaccine uptake. Well, I know and appreciate greatly how fatigued that you are and how much you continually get asked to do. So I'm going to leave it up to you to think about what are some strategies that you can put in place in your practice to raise awareness of pneumococcal vaccination and increase vaccine uptake. Is it possible for you to find 1 week, twice a year, and dedicate it to an absolutely targeted, dedicated recall campaign? And try and get these patients in and have this discussion. You don't have time at all of your encounters with your patients to have discussions around vaccines, but maybe, hopefully, you may have just 1 minute just at the end of your consult with the patient to say, we haven't had time today to discuss your vaccination requirements. On your way out, could you please make another appointment and come back and see me so we can have a chat about what vaccines you should be having? And just finish the consult with that, with just that one tiny minute. So we definitely need to increase vaccine uptake. You can see the numbers here. It's really pretty dismal, absolutely suboptimal. We rely on healthcare professionals having these conversations with patients. Patients have got no idea most of the time what they've had in the past, what there's recommended to them, when should they have it, who can actually give it to them, where should they go to get it. We need healthcare professionals having these discussions with the patients. If you're a little bit unsure around, you know, what's funded, what's not funded, it's all in the too hard basket, I'm going to direct you to the Pneumosmart vaccination tool. It's a tool, it's an algorithm tool that's hosted on the Immunisation Coalition website. It does follow the recommendations of the Immunisation Handbook. We've just done a slight little update to the Pneumosmart tool. I'm still in the process of making sure that everything is correct, but there is that ability to feed back to us at the Coalition if you do find an incorrect or a bit of a glitch in there, and we will jump in and get that fixed straight away. The tool does not calculate catch-up pneumococcal vaccines for children under 5 years of age. Please use the appropriate catch-up vaccine tables that are in the handbook for that. So very easy to use. Just make sure that you tick the little box. I have read and agreed to the terms and conditions of the Pneumosmart tool, and then you can press your proceed button and navigate your way through the tool. The data that you put in, so your patient's name and date of birth and what medical conditions they have, The only thing that gets captured is the date of birth and the medical conditions. The name of the patient doesn't get captured in the back end, so it's all de-identified data. The name is really just there in case you are wanting to print off the recommendations, the recommendation summary, and add it to the patient's notes, scan it or whatever. But otherwise, play with the tool. Absolutely, I put lots of false patients in there, so it could be Bob or Jimmy or Jim or something, and make up a date of birth, but certainly have a bit of a play and familiarise yourself with the tool. So we know that pneumococcal disease, can be a really, really serious disease. There's certainly considerable morbidity and mortality. There's certainly at-risk individuals. And just remember, there's those extended valency vaccines now available, and there's lots of resources that are available for you as well as the product information for your Pneumovax 23, your Prevnar 13, your 15-valent, as well as your 20-valent vaccines. So I think we got there, Andrew.
Angela, thank you so much for taking us on a fabulous first-class tour of pneumococcal disease and pneumococcal immunization, presenting the background, but also some very practical aspects which are relevant to us as immunizers. And thank you for presenting us with a challenge that we need to think ourselves and work together to increase vaccination rates. I'd say it was helpful to see your charts there showing how low vaccination rates are really across the board. And I think that does really present us with a challenge that as immunizers, it's up to us to think about how to address. So thank you so much, Angela, very helpful. And look, lots of questions have come in, which is and I will, as a sort of a caveat, we're not going to get through them all this evening, but those questions that are not addressed will be addressed after the session, and we will be posting them in a few days' time. So I might start off with a question. It's about actually carriage of the pneumococcus. Is carriage really restricted to one or two serotypes, or all of them? And does carriage provide protection itself? So if you've got carriage of these serotypes, are you immunized against them?
Well, I'm certainly, not a specialist in those particular fields, but certainly my understanding is that, look, you may be carrying a serotype or two serotypes, but realistically, you could be carrying any particular serotype. So we wouldn't say that you are immune to, pneumococcal disease. It's an interesting bacteria that can be there and then it can't be there. So you might carry it for several months, but then you may not be a carrier anymore. And because we're not putting swabs up our nose every single day, we really don't know. So the best way forward really is just to get people vaccinated if they are recommended to have vaccines.
And of those serotypes, which is the nastiest? So I think we've got 100 serotypes, which, when you showed the numbers that the vaccines cover, which is the serotype that causes the most severe disease? Do we know?
Look, it really depends on the presentation. Certainly we do know that serotype 3, that sugar-coated killer that we referred to, is a really difficult disease for us to control because the vaccines are not as effective against it because of that extended polysaccharide layer around the outside of the bacteria. And it's certainly probably the one that's causing most community-acquired pneumonias. And, out of all of the pneumococcal disease conditions that we see, obviously community-acquired pneumonias are right up there. That'd be the highest. Yeah.
A 70-year-old person has had their Prevnar, all good. Should they have any more at any time?
If they're a healthy individual, no, that's it. It's just a single dose that we know of at this stage. And of course, you would agree, Andrew, that unfortunately, we don't have crystal balls sitting on our desks. So we don't know what the recommendations will be in the future, but current recommendations is a single dose of the conjugate only. and nothing further if they're healthy.
Sure. Yeah, but if they've got other conditions, if they had COPD, would they have it more frequently?
Yeah, so certainly you would be having a little bit of a look on the list if they've got any of those medical conditions that are putting them at increased risk. Then yes, you would continue on and give them the 2 doses of the polysaccharide vaccine that would be recommended to them, and depending on the condition to whether it's funded vaccine or they would have to self-fund those 2 doses.
And that's a lot of information to remember, and I never remembered, and that's why I use the Pneumosmart tool,
Oh,
which I think is.
excellent. I'm pleased that you use it.
I'm glad that you flagged that. I think that's good. There's a question about, is there a pneumococcal season? We talk about we've got our RSV season and our flu season. Is there a season when pneumococcal disease is more likely to occur?
Generally, no. But however, I will say that because we have this risk, I suppose, with these respiratory infections such as flu that have got that ability to then become a bacterial pneumococcal pneumonia, then yes, you could align that there are going to be some cases more during flu season. But look at our flu seasons now, Andrew. They're starting, they're all year round, really. And yes, we'll have our peaks and troughs, but even interseasonal influenza now is very, very common. So yeah.
So it's a pneumococcal disease that could be a season secondary to other factors such as a viral
Absolutely.
illness.
Yes, correct.
Several questions, a lot of interest around the 15 and 20 strain vaccines. And I think the questions are 2 or 3: availability, cost, and indications. So can you address any of those, Angela?
Yeah, absolutely. Both of them are available on the private market now, so you can be writing prescriptions for them now.
You know how much
Cost-wise,
they cost? Yeah.
well, cost-wise, they are around about $130, $150. However, in saying that, I always suggest to people, if they're buying a vaccine, shop around, phone 8 different pharmacies, they'll get 8 different prices, go where it's cheapest because it's the same vaccine. People with private health insurance, most private health insurance companies will rebate a portion of the cost of a paid for vaccine back. So that will make it a little bit cheaper for them as well. In regards to indications, it's really anybody that's over 6 weeks of age can be having these vaccines if they are recommended to be having conjugate pneumococcal vaccines.
That's I think. And what was the other thing we're thinking about? Indication. Yes. So if somebody, if a patient says to you, look, why should I have this 20 rather than the 13? Can we give them good reasons for it? Can we say, look, you really should do this?
Yeah, look, ATAGI currently are trying to review all of this data to see, what are the benefits of the extended valency vaccines, and should our vaccine recommendations change? And so we're still waiting on what that outcome is. Currently, the handbook would say that there is no preference of which vaccine someone has. If it's a conjugate 13 or a 15 or a 20, just get a conjugate vaccine into the person, is probably what they're saying. But, some people would say, well, there's more serotypes covered, so that's a better vaccine. Some people are saying, well, are we complicating things and by having lots of extra serotypes in there starting to blunt the response of other serotypes. So this is ATAGI's review. This is what they're tasked to do.
So that's a very helpful answer. Thanks. And look, we're approaching 7 o'clock. I'm actually going to cheat a little bit because I'm going to ask a question that's not entirely related to pneumococcal disease, because we've had a few questions up about co-administration of vaccines, and you addressed that very well in regard to sort of Shingrix influenza. So I thought maybe you could tell us this: what vaccination combinations are not compatible? Just any. Is there anything? So in other words, can we give everything together, or is there something we shouldn't? Is that a reasonable question?
It is a reasonable question, and pretty much we can give any vaccine on the same day. You know, obviously it's your live virus vaccines that are, you know, we can give them on the same day, or that I've got to be separated by the 4 weeks. But in regards to these non-living vaccines, realistically, there's not really going to be that big a problem. We do know that some of the adjuvanted vaccines, such as your Shingrix and your Fluad Quad for your flu vaccine for your over 65s, you know, they do have an adjuvant. There's not a lot of data around whether or not that could cause a little bit of blunting. But at this stage, it's about opportunistic vaccine. It's protecting people from disease when you've got the opportunity to do so. So co-administration is great for that. Yeah.
Fabulous. Angela, I'm going to have to close, and you know, I'd like to go talking. There's plenty more we can talk through, and more questions. And as I say, I do assure those who've been very kindly participated by asking questions that they will be answered, and that they will be going up.
Absolutely. No, it'd be my pleasure to answer them.
Yeah. But thank you, Angela. Thank you for answering the questions, for the discussion. Thank you so much for taking us through, as I say, an excellent and very helpful tour. I guess I'd call it a tour of pneumococcal disease and its immunization. Been very enjoyable and very helpful for us. So, and thank you to our participants for being with us and for your questions, and they've given us a lot to think about. I will let you know that our next webinar is an RSV update. It's going to be a close look at RSV, the disease burden, infection rates, immunization, and across age groups. And it's on Wednesday, the 9th of July, in other words, a week today, starting at 6 o'clock in the evening, Australian Eastern Standard Time, and it'll be presented by Angela Newband. So Angela will be back here next week. Registration details are on the website and also in the weekly newsletter. Everyone, thank you. Thank you for being here this evening. I wish you a pleasant evening. Thank you. Stay safe and see you next time.